For today's session, after this overview, we will move into opening review provided by lecturer Karen Kwok, an activity, a UIO spotlight, and an open floor before closing today's event. Our objectives for today include to apply knowledge of key infection prevention and control concepts and actions for flu season, to increase awareness of resources that can help your UIOs to improve your IPC trainings, and to create space for you to share your experiences with IPC. You will also see a QR code on many of our slides today that you can scan to complete a survey and provide feedback on today's event. Attendees at our events this year who complete the surveys will also have the chance to enter a raffle to win some NCUIH merch, so please make sure to provide your feedback. We appreciate your input. To provide some background, the National Council of Urban Indian Health, also known as NCUIH, is the national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas. NCUIH is the only national representative of the 41 Title V urban Indian organizations under the Indian Health Service and the Indian Healthcare Improvement Act. NCUIH strives to improve the health of the over 70% of American Indians and Alaska Natives that live in urban areas, supported by quality healthcare centers. We want to acknowledge that NCUIH is proud to partner with Project Firstline as supported through our cooperative agreement. The CDC is an agency within the Department of Health and Human Services, and the contents of this program do not necessarily represent the policies of CDC or HHS and should not be considered an endorsement by the federal government. Project Firstline is a national collaborative led by the CDC to provide infection control training and education to frontline workers, and NCUIH is one of more than 75 partners across the country who are working to provide innovative and accessible infection control education to help prevent infectious disease threats in healthcare. And here you can see some of our Project Firstline team at NCUIH. In addition to myself, you will also be hearing from Karen Kwok, Marie Zephyr, and Zoe Harris in today's event.
I'm really glad to have everyone here today. I'm a nurse practitioner and returning NCUIH contractor. Today I'll be leading us through a flu review to remind you all of key IPC infection prevention control concepts and actions to keep in mind during this viral season. And please note that the slides from today's event will be shared with you all via email. Next slide, please. Influenza or flu is a contagious respiratory illness caused by influenza viruses, with the two main types of flu viruses being types A and B. Examples of common flu symptoms might be chills, fever, runny nose, or sore throat. So common diagnostic methods include RIDTs, rapid molecular assays, and viral culture to help discern from other causes such as COVID or the common cold. Flu treatments like antiviral drugs are most effective when they are initiated early on after symptoms begin. Next slide, please. So how do viruses like the flu spread? We know that reservoirs are places where germs live and are a key element of how germs spread, and the respiratory system is a major reservoir for these flu germs. They often infect the nose, mouth, and throat, and the common pathways by which they spread include coughing and breathing in the flu germs. Next slide, please. Now let's dive deeper into how flu spreads, which is mainly through infected respiratory droplets that are released when infected individuals cough, sneeze, or talk. These infected droplets can lead to infection when they land directly on the eye or land on surfaces where people can touch and then touch their nose or their mouth. Those infected with flu are most contagious in their first 3 to 4 days of being sick, with symptoms typically starting 2 to 4 days after the respiratory tracts are infected. Next slide, please. So what we can do to prevent and control flu infection. One key action you can take is covering your nose and mouth with either a tissue or your elbow when you sneeze or cough, cough hygiene, cough etiquette. You should never sneeze or cough directly into your hands, and you should use proper hand hygiene after coughing or sneezing. Next slide, please. There are many resources which can help to improve your organization's IPC trainings on respiratory hygiene, including CDC Project Firstline materials like the infographics shown here. The CDC also has infection control assessment tools, which are best used as administrative tools by facility leaders, and these can help you to understand areas of IPC like respiratory hygiene that can be addressed at your organization. Next slide, please. Another key action you can take to prevent flu spread is to use proper hand hygiene. You can see some tips here in making sure that you're covering your hands and rubbing your hand surfaces effectively with the hand wash. You should also make sure to avoid hot water that could dry your skin and use lotions that are only approved by your facility, which do not interfere with the effectiveness of soaps or sanitizers. Germs can also live under artificial fingernails even after hand washing and use of sanitizer. So keeping your nails short and avoiding artificial nails will help minimize that germ spread. Next slide, please. Alcohol-based hand rubs and hand sanitizers are often preferred in the clinical settings, but still make sure that the effective technique is used where you cover all the hand surfaces and rub the product around. And you can see some suggested motions here. Hand rubs are less likely to irritate your hands. You should also make sure that you are using an alcohol-based hand sanitizer that is at least 60% in order to effectively kill the germs on your hands. Next slide, please. Knowing when it is best to hand wash versus hand rub can depend on the circumstances of your care setting. So for example, it would be typically recommended to use an alcohol-based hand sanitizer versus soap when doing routine patient care. However, if you notice that your hands are dirty or soiled, then definitely washing with soap is the preferred method. The list here is not exhaustive of the possible reasons to clean your hands. The most important thing is effectively using the method that is appropriate, consistently, and effectively. Next slide, please. Here are some examples of resources that can help your facility with its IPC practices and processes, including more CDC Project Firstline resources and relevant CDC infection control assessment tools. Another way to stop the spread of flu germs, next slide, please, is to make sure that you are effectively donning and doffing your PPE appropriately. There's not only one correct way to put on or take off PPE. These are just some suggestions to effectively do so. Next slide, please. Here you can see more examples of CDC resources related to PPE, like Project Firstline trainings and interactive resources, as well as CDC infection control assessment tools. Next slide, please. Effective cleaning and disinfection are also important for reducing flu spread. Cleaning removes dirt and germs, while disinfection kills germs. Some of the surfaces that should be cleaned and disinfected regularly include high-touch surfaces like keyboards, light switches, and bed rails. You should always make sure to read the entire label of the cleaning and disinfection products used by your facility, and the CDC has released a helpful infographic for reading disinfection labels that you can see here. You should be particularly cautious to consider contact time, which is the amount of time that a disinfectant needs to sit on a surface before it's completely aired out and allowing it to be effective before wiping. Next slide, please. Resources like these that were mentioned already from CDC Project Firstline and CDC infection control assessment tools can also help your organization with improving cleaning and disinfection. You'll see now in the chat box the link to the CDC Project Firstline infographic on infection control actions to stop the spread of viral respiratory infections like influenza, RSV, and COVID. Next slide, please. You should also make sure to get your flu shot to protect yourself and others from the flu. Getting your annual flu vaccination helps to reduce the risk of severe illness, hospitalization, and death from influenza. Annual flu shots are recommended for everyone aged 6 months or older with certain exceptions. All flu vaccines are quadrivalent, meaning they have 4 components and help to protect against 4 different flu viruses. You can also get your flu vaccines and COVID-19 vaccines at the same time. Next slide, please. So let's dive deeper into flu vaccinations. Getting your flu shot can help reduce the risk of getting sick, hospitalized, and dying from flu, as mentioned before. Flu shots also help to protect yourself and those around you who may be more vulnerable to serious flu illness, like infants and children, those who are pregnant, elders, and those with chronic conditions like heart disease or diabetes. The CDC shares key updates for each flu season, and this year's updates include updated recommendations for flu vaccines for those who are 65 and older, an updated recommended age for the Flucelvax quadrivalent flu vaccine, and an update on the expected availability of certain flu vaccines. There are also many resources available to help you improve your trainings related to vaccinations like flu shots, including CDC Project Firstline resources such as training toolkits and videos related to multi-dose vaccine vial safety. Next slide, please. Finally, we want to reiterate why all these infection prevention and control actions are particularly important for the population served by urban Indian organizations. American Indians and Alaskan Natives are at higher risk for developing serious complications from the flu, like pneumonia, bronchitis, and encephalitis. Flu and pneumonia are both among the top 10 causes of death for AIAN peoples, with disproportionately higher rates of death from these conditions compared to other races in the US. You can also see how the disparities range in flu hospitalization rates, admission rates, and vaccination rates. By employing different and effective infection prevention and control methods in a multi-layered approach at your organizations, you can help to address and reduce these same disparities. Next slide, please. So now we would like to open the floor for any questions about what we've discussed so far. Please feel free to unmute yourself or type your questions in the chat box before we continue with today's event. Thank you. Awesome. Thank you, Alyssa, for sharing that question in the chat box. Now, for the to-dos about hand hygiene, it's pretty common. We remember the 22nd birthday song, but what about the not to-dos? So the don'ts are avoiding any antibacterial soap because there is a concern about resistance to antibiotics. Being careful and avoiding use of dirty or contaminated water because it actually puts the germs right back on your hands. Using hot air hand dryers, which can make your hands more dry and irritated. Touching the sink or fixtures immediately after washing your hands actually leads to cross-contamination. So I usually dry my hands with a paper towel and then use that same paper towel to turn off the faucet. And forgetting to wash between procedures, even when you're with the same patient, as you can transfer germs between different reservoirs, such as from the gut to the skin, if you were happening to help a patient who had incontinence, for example. So those are some not to do's to be careful of. And thank you, Zoe, for the question regarding when to take the COVID flu shot, when you have a COVID infection. So this is a concern that is not I repeat, not related to safety of the vaccine or complications related to that. Instead, what we want to make sure is to ensure that the patient has adequate time to recover from the COVID infection itself, that they are not going to be infecting others who might be administering the vaccine. So ensuring the safety and well-being of the staff who would be administering the flu vaccine. And then also, if there happens to be like a slight fever or general malaise and feeling fatigue after the COVID vaccine, you can see how it could be potentially misconstrued when someone is recovering from the actual COVID infection, where they would be two separate scenarios, separate instances. So you want to give yourself enough time to recover from the COVID infection before getting the flu vaccination. So that's a very good question. Thank you, Zoe.
Karen, I know that you said that folks are the most contagious the first 3 days. And so when can staff return to work after? So if they do come down with the flu, what's a good timeline for when staff are able to return to work?
Another good question. So between 2 to 4 days is when they can really be infectious as well. And so you want to just give yourself, again, enough time to recover from the infection, where there is at least 5 days from recovery from the flu, at least 24 hours since having a fever without any use of Tylenol or ibuprofen to bring down the fever. And really, it's to ensure the safety and well-being of not just your staff, but patients who could be vulnerable for getting the flu. Now, of course, if you happen to have either immunosuppression or an autoimmune condition or chronic disease in which you would be more likely to be shedding virus for a little bit longer period of time, we do recommend checking in with your primary care to make sure that you're recovering well enough. And then because there might be a longer term of possible viral shedding, you want to check in with your primary care to make sure it's safe to return as well. I'm just taking a look at what Aaron had put in the chat box. Bacterial infections are resistant to alcohol rubs, C. diff, and bacillus. Thank you for sharing that additional information. And so again, that just speaks to a multi-layered approach and being sure that we do not spread C. diff or bacillus further. Thank you, Felicia, also for making the comment about the audit tools. And so just wanted to highlight one of our UIO partners who's been with us since the first year of Project Firstline's partnership, where actually it was just updated to be a little bit user friendly in terms of being a checklist, and then it was broken down into the different modules like hand hygiene, for example, and it does include some updates about artificial nails, for example, so they can be used in the outpatient setting. Any other questions or points of clarification or additional tips in this learning community together?
Yeah, Karen, I actually had a quick question. In regards to contact time for disinfectants, I've heard several people mention to me that if a disinfectant says that it requires 2 minutes of contact time, they'll wipe a surface, but then they note that surface dries maybe in 30 seconds or a minute. what would the recommendation be if you notice that it dries before the total contact time? Would you wipe it again, or does it just mean it needs to be there without wiping it off for 2 minutes total?
Good question. So again, contact time is the amount of time that the disinfectant needs to stay remaining undisturbed to fully kill off any germs on, for example, a high touch surface. So you do want to observe what was listed in that label for safe and effective use of the disinfectant, and the full 2 minutes should be observed and not sooner in terms of wiping it down afterwards. But that full 2 minutes is the contact time that was listed by the disinfectant label, and that's the 2 minute time to be observed. Thank you for bringing out that highlight. I also saw in the chat box from Paul Gentile, thank you for sharing. Love the disinfectant diagram. Many people don't realize there's a contact wet time on the containers. Yes. Thank you, Paul, and feel free to add 2 cents if I've left out any specific details, Paul. Also, just to remind the audience members here, we have the resources and the slide deck available to all who participated here today, and those are our visual aids, job aids that can be used in clinic as well. I might add one thought, as I know this often comes up with many of my patients when they are debating whether or not to take the flu shot or to wait. And it comes from a clear understanding of who's at risk for complications with flu, which again could be as serious as even pneumonia, endocarditis, encephalitis. And while one may not have a chronic disease like diabetes or heart disease, you might very well be in contact with children in your home where they would be at risk, particularly if they're under 6 months of age and are not yet eligible to receive shots. If you happen to visit elderly parents or have older relatives in your extended family, and they may be at risk if you are passing on flu germs. So again, those are some individuals in our community that we should consider for protection by proxy if we get our flu shots on an annual basis, particularly being in the healthcare setting. And I wanted to give everyone an opportunity. Later on, you can ask questions or go ahead and put in the chat box any other points that you would like to make sure we cover. But I'll go ahead and pass this on to our next section here. So that would be Marie and Zoe, but I'm here if there's any other questions. Thank you.
Thank you so much, Karen, for that overview. Medakya, our relatives. My name's Marie Zephyr. I'm Betuwashde. I hope you're all having a good day. I'm proud to be part of Project Firstline team here at NCUIH, and today's community of learning really was devised around best practices for hand hygiene. And I just wanted to encourage you all as healthcare warriors and those that serve Indigenous communities to practice self-care. And so this afternoon, I wanted to take a second and share something that I know from my Lakota culture, to ask for guidance in all the things we do. And so in Lakota, we say Wakatanka, our great spirit and mystery, Unkashla, which is the grandfathers, and Makashkashka, the spirit in all things. Thank you for all the commitment and the hard work that the people here in this room and the healthcare warriors across the nation serve for our patients and making sure that we have healthy communities. I ask that you please wrap your arm of protection around them, as well as the patients and overall people they serve. Opila Tonka, many thanks, and Matakyase, we're all related. I just wanted to share that message because I think it's powerful and demonstrates self-care for healthcare warriors like all of you. Thanks for your time, and now I'm going to pass it on to Zoe for her introduction.
Thank you so much for sharing, Marie. Again, my name is Zoe Harris. I'm a citizen of the Mashpee Wampanoag tribe, and I'm happy to be here with you all today. And today we're going to be testing our knowledge on infection prevention and control concepts and actions. And Marie will be going over our activity.
Sure, thanks, Zoe. So for today's activity, we're going to use Poll Everywhere, and you can use this on any device that has internet access. If you have an internet browser, you could use pollev.com/wiredsun334, or you can actually text today's responses to wiredsun334. And the text number that you would use is 22333. There's also a QR code on the slide that you could take a picture of and join. And these instructions will be placed in the Zoom chat, so don't worry if I talked a little fast. I'd also like to note that all responses are anonymous, and even if you're prompted to enter your name to join the poll, we'll welcome you back and make sure your name's not shared. So please share your comments and thoughts either out loud in the chat and through the Poll Everywhere. And I'll pass it back to Zoe.
All right, so we are going to start with our first question, which is a true or false, and we'll give people a second. But the question is, flu viruses mainly spread from droplets that are released when infected individuals cough, sneeze, or talk, and you can select true or false. All right, we have one for true. And again, you can respond either online using Poll Everywhere /WiredSun334, or you can text WiredSun334 to 22333, and those are also in the chat. So the correct answer was true. So it looks like everybody who has responded was listening to the lecture. They've been doing some great IPC work. And the flu viruses do mainly spread from infected droplets that travel through coughing, sneezing, or talking. And now we'll go off to the next question with Marie.
Okay, so now we're going to go through a scenario. And this is also going to be using Poll Everywhere. So Morgan's a UIO nurse whose facility has a vaccine tent at the local community health fair, and they're there to administer flu vaccines to local residents. Morgan's currently wearing a mask and a disposable gown without no other PPE. She's using her cell device when a local resident approaches her. The resident's wearing a mask and requests to receive the flu vaccine. Morgan immediately grabs a clipboard and pen to hand to the patient to collect their background information. Then Morgan immediately reaches for the flu vaccine vial to begin preparing the vaccine dose. So what are some of the infection risks that you can recognize in this scenario? As you share out your responses, they'll appear on the screen. You can also unmute yourself or answer in the Zoom chat if that's more comfortable. Yep, no glove, cross-contamination, another cross-contamination. Anything else you could see with her use of PPE that might be potentially negative to the patient? Yep, the bloodborne pathogen, no hand washing between phone and clipboard, no gloves, phone to flu vial. She can transmit from the clipboard and pen as well. She needs to use alcohol rub before vaccination. Morgan needs an assistant to handle her paperwork. I agree. I think Morgan can use the assistant. She also needs to utilize hand hygiene and cross-contamination touches to many objects. Yep, we're seeing a lot of the similarities. You guys are paying excellent attention. And she also had no hand hygiene. Are there any other responses? Does anyone have any comments? Yeah, the phone's probably not clean. I agree. Think of all the places we take our phones. It sends a poor message to the patient about proper PPE usage. Yep, I think we could all remember when COVID first started and there was so much information and misinformation. Okay, well, are there any comments about the vaccine vial? Now Karen's testing our knowledge. Okay, well, if there's not anybody specifically wanting, I'm gonna ask Karen, would you just comment on the vaccine vial? Oh, here it is. I spoke too soon. Well, there's an issue with the vaccine storage and what's the UIO's procedure and protocols. And then now go ahead, Karen. Do you think she?
I was just preempting that injection safety with multi-use, multi-dose vials.
Definitely. And we got good insight from Melissa in the chat that they're good points. And as a nurse, she found it difficult not to realize that these small touches in between actions, such as touching your hair or your face, they really matter. And you don't realize that could spread the infection. But thank you so much for your time and participation. I'm going to hand it back to Zoe.
Thanks, Bree. So the next question that we had is, what are some examples of reservoirs and or pathways for germ spread in this particular scenario? I think that we had a few good ones in the last slide, but if there's anything else to add, we had talked about the phone, the clipboard, people's hands. But again, we want to make sure that we're really understanding like what are the reservoirs and how exactly are germs being passed to each other here. Touch. Skin reservoir, yes, definitely. Yes, a lot of touching things. I think that kind of Karen's comment about artificial nails, I think that also applies to phones here. We don't really always remember how many germs are everywhere. I am also guilty of not always wiping off my phone, so definitely agree with that. Perfect. I think because we covered this a lot in the last slide, objects, yes. We can go to the next question just so that we can get through the next scenario. You can go to the next one. Great, thank you. So the next question that we have is, what is the difference between cleaning and disinfection? Is it A, disinfection removes dirts and germs while cleaning actually kills germs? B, cleaning removes dirts and germs while disinfection actually kills germs? C, disinfection always comes before cleaning? Or D, there is no difference between cleaning and disinfection? And I will give everybody a moment to think about it. We have some answers for B. And then I see Eddie's chat from the last question. I wonder if Morgan changes disposable gowns between patients. If not, the gown could be a reservoir. Also a good point, Eddie. Thank you. All right, it seems like I can't trick anybody because the correct answer was B, cleaning removes dirts and germs, which while in disinfection actually kills germs. And we will now go back to Marie for our next scenario.
Thanks, Zoe. Okay, now for the second scenario, we'd like to go through a health educator named Alex. He actually works at a UIO that provides clinical care. However, he is not wearing any PPE. They're using one of the shared computers in their facility, and he works on developing materials for a flu vaccine promotion campaign. While Alex is working, other coworkers are eating a snack with their hands. Then a UIO doctor approaches and asks Alex if they can use the computer. The doctor has just left the patient care area and he's still wearing his gloves. Alex lets the doctor use the computer mouse and keyboard, and after the doctor leaves, Alex goes back to working and snacking. What infection risk can you recognize in this scenario? And as before, you can either type your responses, chat them, or if you get really brave, you could shout them out. Use the poll everywhere as well. Yeah, we have a comment that says, oh my, no doctor should have removed gloves and clean hands. Any other comments?
I have a comment. It makes you wonder where this doctor's been, not just to this workstation, but throughout the clinic.
Yeah, this is definitely another example of cross-contamination. And he had no mask in the shared working space. And also, who knows about the other coworkers and what departments they were in? That goes hand in hand with eating in the shared workspace in the clinical office settings. What about examples of reservoirs and pathways for germ spread in this scenario? Yep. Definitely eating at the workstation, no gloves, that skin contact. You guys have some great ideas, hand to mouth. Thank you for that. Computer gloves not removed. And with that, I'll pass it back to Zoe to wrap it up. Thank you guys for your participation.
Reservoirs. Thanks for going over that, Marie. So I think that we can go to the next question. I think we'll just pause for a second. And we talked about all the things that Alex should not have done, eating at the workspace, not wearing a shared mask, but what could he have done or they have done to make sure that the IPC actions were taking place, and when should they have done that? And we have some comments in the chat from Karen. Environment reservoirs can also include water and wet surfaces, dry surfaces, dirt and dust and devices. Yes, all really great points. I think that Evie also made a great point that we don't also, if they're doing in this one space, where else have they been in the clinic? Yeah. Disinfected computer devices. Yes, definitely. Do not allow food at the workstations. Yes, that's definitely a very easy one. Clean the workstation before use, taking a break to eat snacks in a designated area, ask the doctors to remove gloves / clean hands. And it looks like Paul has put a resource into the chat, which is great. Wash hands before eating. Thank you all so much. And we'll go to our last question before we move on to our next section. So for our last question, this is a true or false. The CDC recommends only using alcohol-based hand sanitizers that contain 30% alcohol or less. Looks like we have some answers coming in. It looks like there's some debate on this. Oh, okay, maybe not. So maybe you changed your mind. But it is correct. The answer is false. So you should use an alcohol-based hand sanitizer that is at least 60% alcohol. And again, thank you all for participating in this activity. We hope that this helped to improve your understanding of IPC and better prepare you for this viral season. And now I will hand the floor over to Libby. Thank you again, everyone.
Thank you so much. Let me go ahead and unmute myself. Sorry. Thank you. Today we're going to be doing what we call a UIO spotlight. Now we could take a moment to do a spotlight, which is really giving the opportunity for our UIOs to shine. So at each of our community learning events this year, we will be using this time to hear from the different UIOs experiences with infection prevention and control. This may include best practices, challenges, lesson learned, or any other reflections on their individual and organizational experiences. Next slide, please. For the past 2 years, UIO recognized and awarded by NCUIH, they were IPC champion sites, and they have created, enhanced, or sustained some of the following activities. At Denver, they implemented an all-staff competency day. This involved the development of 7 training stations for employees, and by group, the employees were they were cycled around the clinic. They circulated around the clinic and completed the various trainings. Some of the trainings included needle stick prevention, safe injection practices, exposure procedures, hand washing, spill kit, and others. And they did this type of training twice a year. Some of the other work they've done there at Denver included virtual training for the staff as well. Everything from SteriSafe, SteriSafe HAZCOM training, hand hygiene, the SteriSafe bloodborne pathogen training as well. In 2022, the ambulatory outpatient surgical service, they did the virtual courses as well. And they utilized, at the time, NCUIH offered scholarship, and they utilized those dollars for the dental director and the medical support staff managers to attend courses online. At Fresno, they actually revamped their safety committee to have dedicated IPC focused, and they met monthly. And their functions as a QI subcommittee and uses CDC assessment findings and the AAAHC accreditation guidelines to improve their program. They also worked at Fresno on implementation of job-specific training for healthcare professionals. They worked on updating their policies, creating new workflows that really honored and respected some of the IPC components. They received training through NCUIH and CDC, all approved by the board. And so the other neat thing they did was they created competency assessments and annual staff training with knowledge checks. And our Bakersfield, our sites, working very hard, and they continue to educate and support their staff by setting up set clear processes and policies around hand hygiene, the proper usage of PPEs. They've instituted mandatory sessions, training sessions on biohazard waste disposals, disinfection cleaning schedule, bloodborne pathogen training. One of the neat things they've done is, and they did in the last year, and they continue to do, is to create safe, clean, infection prevention culture and establishing accountability among their organization, their staff, by creating surveillance and auditing practices. So by doing, for example, a PDSA, or what they call Plan, Do, Check, Act, for continuing and that continuation and creation of sustained IPC safe staff habits. They also establish and carry out objectives and process, evaluate the data after they do that, set a certain protocol in place, the procedures. They'll go back and monitor, and they'll reevaluate, identify gaps for potential improvement for the team. And then they also inform the risk management processes and the quality improvement plans as well. So that was their comprehensive approach to really create a safe, clean infection prevention control culture at that particular site. So for really briefly, I just wanted to share those types of opportunities that our UIOs have taken upon themselves. And I really appreciate that some of our representatives from these sites are here today. Next slide. Moving forward, and we'll share this and we'll drop this in the chat, and also you'll receive an email with more information on this. For our UIOs that are participating today and in the future, if you are interested and you'd like to share what type of work you're doing in and around IPC, please email us at ipc@ncui.org. You can also register at the IPC Assistance Center, and you can actually upload some of the work that you're doing. On your screen, you see a template. We're going to use a storytelling type of approach where you're going to tell your stories about what you've done in the work of IPC at your respective UIO. I'm going to hand this back to Sophie. Next slide. Thank you.
Thank you, Abby. Does anyone have any questions about any of the things we've talked about so far, from the flu review to the sub-areas we discussed, to any questions about the UIO spotlight? You can feel free to share any final thoughts, comments, or questions on the event for a specific presenter or for the general team, and you can unmute yourself or place your questions in the chat.
If I could just highlight from Evie's session and the storytelling as well in Zoe and Marie's section, it's all hands on deck. I think that's the main emphasis, is that our protection of our community members is not just in the exam room. It happens at every point of contact, where there's been great highlights from Bakersfield on how to properly clean a medical transport vehicle to keep patients safe between each drop off and pickup. And that particular approach is very unique to a resource that has been shared by our UIOs. And then also administratively, what does it mean to support and ensure that the staff members have the resources, the protocols, procedures in place to have a infection-free workspace, not just for staff, but also for patients. So those were great highlights that I had heard in all the different sections.
Thanks for sharing that, Karen. Any other questions from our audience today, or final thoughts or comments?
I had one final thought, just reflecting on the whole lecture that Karen provided and thinking, you know, from my clinical practice as a nurse, where when I think of flu, I think really of like breathing in viruses or masks. And sometimes I would forget about those cleaning and disinfection and the touch. And so I really appreciate your lecture, Karen, and highlighting the hand hygiene components, because I think that that sometimes gets forgotten with flu.
And this is a building upon the infection control methods and perspectives that we already had in place. It's that consistency of effective approaches and layering in a multi-layered approach, all the tools, resources, and knowledge that we have together. So that was a good point to bring up, Melissa. I know we also have infection preventionists in the audience here, and some of them are new attendees, which is great. I would love for you to either type in the chat box or go ahead and unmute yourself. Any particular lesson learned that you had in your clinical setting regarding flu vaccination and infection control for our current viral cold season. Any thoughts from the audience, please?
Hello, Karen. This is Johnny from Bakersfield American Health Project. I just wanted to share that this flu season was probably one of the most challenging for our UIO, given the pandemic. A lot of it stems from political reasons, such as the president declaring the pandemic's over and everybody not wanting to wear masks anymore, or disinfect properly and such. So I could say this flu season was probably very challenging for us because of that. Because is it COVID? Is it not COVID? Is it the flu? All the symptoms are the same. And then the exposures as well. Additionally to that, California law has been very challenging as well, and what the requirements are. And even with Cal OSHA, they have the emergency and temporary standards, which we have to abide by, but then we're also in an exemption for airborne transmittal disease, which has its own set of rules. So I can say that this is one of the most challenging periods for us, has been through the flu season, because of the rates being so high, where I would have multiple staff out at any given time just because they were exhibiting symptoms. And we can't force them to stay home when they have the flu, and the flu does spread. So it did cause other people to get sick, them being at work, where they're infecting others, but we can't force them to go home even though they're sick, because they're technically capable of working. So I just want to share that for us, it's been really challenging for us as a weight because of that. So hopefully as we move through flu season, we'll experience a lot of relief from that.
Thank you, Johnny, again for attending and for your thoughts, particularly something to offer up for insights, suggestions, tips from the community of learning here. And you bring up a couple points. First, about just the common baseline of these symptoms shared between flu, RSV, and COVID, and you really can't tell them apart. And so the diagnostics needing to be in play very early on, because it can certainly determine what is the actual cause, what are the treatments available, and then the isolation that's needed, particularly when we're talking about COVID and the ramifications for the safety of staff and patients. You brought up the point about fatigue of your staff, and we actually have that upcoming as a topic, so keep your eyes out for that event. And certainly we would love to have these specific UIO examples so that we can make the content relevant and pragmatic in terms of things that could be resolved with resources that we can share, not just from the presentation, but also as a community of learning. And then lastly, I just wanted to see if there were additional thoughts that other clinical sites have on how they had resolved these same challenges, whether that be speaking with their employees, their staff, about mandating masks again. Any thoughts? And actually, I do see, thank you, Paul, for jumping in and sharing a comment in the chat box. Paul Gentile said, influenza definitely came early this year with RSV and COVID. It's important to get vaccinated to reduce hospital patient encounters, and definitely completely agree. Prevention is key here, but definitely when you come upon symptoms and symptom management and employee compliance, what strategies, what solutions have individuals had here? And I know in the audience we have those in attendance from not just I think New Haven, but also in Fresno. And again, it can even be a question, not necessarily a solution or a commiseration of these same challenges too. Go ahead.
Hi, good afternoon, everyone. This is Felicia from Fresno. I feel for you, Johnny. We have not experienced what you've described, and especially to that level. So we're super blessed. As you were talking, it brought up kind of the COVID hours dance that we're doing with our staff in terms of, can you use COVID hours? Do you use sick hours? Are you out of COVID hours? What hours can you use? So that's been more of our space, but that's because we've also had a gap like in our HR staffing space. So that's been an interesting kind of situation. And now there are no more COVID hours. So now, you know, just kind of quote unquote getting back on track and figuring out how to cover sick time for individuals who need to take it. And for us, we actually still maintain a policy of people go home if they have symptoms. And then we work out the coverage pieces later, both for their position as well as if they happen to be out of sick time. So that's been interesting. And we still maintain a mask at all times. So PPE is still in place for our workspace, both for our staff and clients.
Thank you for sharing and chiming in, Felicia. Definitely offline, I wonder if yourself and Johnny can connect about that. I'm sure you have more specific tips about what policies are in place for you to allow for patients, staff members to stay home and not create more patients and more germs that are being spread. So I really appreciate that.
Thank you, Karen, and thank you to everyone who's shared so far. If you do have further questions, we'll stay on, but I want to offer a few reminders before people get going from today's event. So NCUIH has an IPC Assistance Center that you can join to access and share resources, interact with each other and other UIOs, and more. The link to register will be shared in the chat, and you can also visit our website, email our team, and listen to our podcast. All this information is in the chat and will also be emailed to you as well after the event. And we also have a lot of resources to share related to today's event. And again, these will all be shared afterwards. We also have more community learning events coming up later this year that we hope you will attend. So NCUIH has other additional events here, such as a new on-demand community of learning series on person-centered care. And our next project event will be Thursday, March 16th. And it was mentioned earlier, but this one's going to be focusing on taking a storytelling approach to burnout and IPC. So we hope to see you all there. And finally, we'd like to remind you again to please complete our survey to provide feedback on today's event. So you can scan this QR code or use the link that's shared in the chat. Survey respondents will be offered the opportunity to enter a raffle to win something from NCUIH. So make sure to fill this out. And with that, we thank you all again for joining us today, and we hope to see you all at our next training event. So have a good rest of your day, everyone, and we'll stay on for a few more minutes as well if anyone has any further questions.